how do we see this changing, field going forward? We have this excellent data, and obviously, sequencing of these drugs also comes into the picture, at least in the medical oncology field. We gave all the best. Obviously, we wanted to use the best available therapy up front, which is, the triplet therapy, and then how do you think about that as far as, what would be the next, if they get the triplet therapy, if they progress, what are your options, or how do you think about that?
I think one of the frontiers of the patients always ask is, after they've completed the sequence or they are started on a novel oral with ADT, they say, do I still have to get the shot? And I think there's some trials ongoing with monotherapy orals now that are looking promising, and is the cardiovascular risk from the leuprolide or those types of things, will they be minimized with just the oral agents? And so that'll be interesting to see if they get less quality of life or long-term toxicities if they could just go to an oral agent for maintenance after treatment.
Yes. I think the natural course of it has thus far been, it started out with the post-chemotherapy indications for castrate-resistant prostate cancer. Then it became hormone-sensitive prostate cancer. So I think and every 2 years it gets approved, and the first drug gets approved, and the second drug of the same class gets approved, and then all of them are approved. So I think just natural progression would be to eventually get to monotherapy. Mm-hmm. And again, hoping that eliminating that massive effect that Lupron or Orgovyx or any of those medications can have will make a major difference, particularly again in this, that extended study showing the cardiovascular risk effects. Yes. So having that monotherapy may also be a big game changer for quality of life and for treating prostate cancer. So.
Yeah, no, I think, definitely this is an important aspect, especially the cardiovascular health. It's a big, concern. As we know, these patients live, several years and stays on this hormone treatment for a long time. So they definitely needs to have a very close monitoring of their, heart health, and again, that brings back to the point of having that collaboration with different specialty, including cardiologists. If they have a known cardiac history and issues, then they need to be, involved. So, great point. How about other newer therapies? We have lutetium 177 that has now been approved for metastatic castrate-resistant prostate cancer, and there are a lot of other studies going on where they are trying to move those agents, in a frontline setting. So we obviously going to have a lot of new data and maybe newer sequencing regimens in the future. So, how do you think about that as far as where we stand and where we will go with this newer data?
So my first experience to lutetium was a patient who would fly to Germany, get it done, fly home. Wow. And every period, his PSA would then creep after a year or so, fly back to Germany, get it done, fly back. Now it's here. Yes. You do it, yes. And we have someone in common. It wouldn't shock me if in a year or so it's gonna bypass the chemotherapy,
agents. So it might get approved prior to chemotherapy, right? Understood.
It's cell specific, as opposed to chemo, which is body specific. Yes. You want to call it like that.
Yeah, and that also brings an important point about the availability of the drugs, right? I mean, prostate cancer is so common cancer. We have so many patients. And when these drugs get approved, as we know with the lutetium in the beginning, there was a very difficult time where the drug was not available because they were not able to make that drug in the enough quantity. So, we're going to have to wait and see how this pans out. And we hope that, the industry and we are ready to have these drugs to the patient if and when that data comes out and gets approval. But yeah, great point.
Can I ask you a question?
Yes.
So what is your algorithm when it comes to using any of these novel therapies, these receptor inhibitors? Because the gray zone that I always feel is, which one do you use first? Do you save one for later? Is one better than the other? Should I try this one? And if they tolerate it, then great. But if not, then I'll switch to this one. What is your thought process with that? Because that's always been confusing. Yes. And I feel like it's a little bit of kind of a picking out of a hat to say, well, let's just do ADT plus this, or maybe we should do ADT plus this. But there isn't necessarily an absolute rhyme or reason other than potentially side effect profile. Mm-hmm. But
Yeah, so I think this situation comes more common in castrate-resistant population, right? They are already on ADT. They probably have seen chemotherapy more than likely nowadays because we are using that upfront in the hormone-sensitive space. So by then, the currently approved oral androgen receptor inhibitors for castration-resistant space, you have Zytiga and Xtandi, and really, in terms of the efficacy, I feel that they both are equal. In terms of the efficacy, you really, have to choose, with the Zytiga, they have to take the prednisone. So for example, you are worried about them taking prednisone for a long time, then you might consider using Xtandi. And also, there is a small risk of, seizures and neurological issues with these drugs. So if you have a patient who has a known neurological problems, then you wanted to choose the drug that has a less CNS penetration. So I think these are some of the perks, but in general, it's it really, and a lot of practices will have their own preference. They wanted to just stick to one agent. Hey, we're just gonna use Zytiga or Xtandi and just make it more simplified, because as we know, there are a lot of people involved in this process. Just not you, the pharmacist, the patient assistance team, the nurse navigator. So to have a simplified algorithm sometimes helps them. So yeah.
So and then there sometimes comes up with the darolutamide is for non-metastatic castrate resistance, but you can have lymph node positive in
That
those
is correct.
patients and treat them on label.
Yeah.
So for patients that have tolerability, or so there is a window of opportunity there that I don't think everybody always remembers.
Yes, and I think that's a great point. So I think that's an Aramis trial that looked at the non-metastatic CRPC population, and they allowed patient with the lymph node involvement up to 2 centimeter in size. So if you have a patient who fits in that criteria, I think darolutamide along with ADT would be an excellent choice. So good point.